Over the past, I'd say almost 1 to 2 decades, we've been treating patients who end up reactivating their CMV, sort of treating them preemptively if they show up with a CMV. Explain that to me, and how frequently, what agents are used traditionally, and when you initiate therapy.
Yeah, so preemptive strategy is a very effective method in preventing CMV going into various organs and causing disease. And so with this, in this era of very sensitive molecular assays, CMV disease is probably around 5%, depending on the risk. But I would say that for the standard risk patients, it's about 5%, perhaps at higher risk, even closer to 10%. So we monitor, and once the patient develops CMV viremia, we start treatment with ganciclovir or the oral form of ganciclovir, valganciclovir or Valcide.
Now, I know at our own institution that's often quite effective, but there are complications with those agents that make it sometimes difficult to use.
Right, so some patients that reactivate CMV quite early, their blood counts are still low, and they cannot even get ganciclovir in the beginning. We have to use foscarnet, which is given intravenously and carries significant nephrotoxicity. But if the patients that can receive ganciclovir, several of them eventually may develop cytopenias, may develop neutropenia, thrombocytopenia, and potentially we have to either lower the dose of the medication or stop it completely.
Now, I know there's some controversy about the level at which to start preemptive therapy when one gets CMV reactivation. What levels do you use at your institution?
We stratify patients as high risk and low risk. And the patients that are at high risk, we start actually at any detectable CMV viral load, even beyond the level of quantification. In the standard risk, we probably want to see a couple of consecutive positive viral loads. And I would say that if we see a trend of rising and about 500 international units, then we start a treatment.
Obviously, patients who get into trouble with cytopenias are susceptible to other infections, right? With bacterial infections and fungal infections. So it's not just the CMV itself that can cause complications, but it can actually be, there could be complications from the treatment of the CMV.
Certainly. So cytopenias predispose to, as you mentioned, bacterial infections, so bacteremias, fungal infections, and even more importantly, CMV itself has an immunomodulatory effect and creates a greater degree of immunosuppression. So patients may actually be more susceptible to other viral infections. And so CMV really affects non-relapse mortality, and a number of retrospective cohort studies have demonstrated that CMV seropositive patients have lower survival compared to CMV seronegative patients. And those patients that had CMV reactivation also have lower mortality, higher mortality compared to CMV seronegative patients.